So, dear participant, we are ready to start. My name is Mariangela Pellegrini. I'm the Educational Patient Program Manager for the ERN-EuroBloodNet, and it's my great pleasure to welcome you on behalf of the ERN to the 5th topic on focus on thrombotic microangiopathy webinars for health professionals. As you may know, this program has been developed by a collaboration between the ERN and the French National Center for Thrombotic Microangiopathies, the CNR-MAT, and will consist of 15 sessions. Furthermore, this program is accredited by 11 continuing medical educational points, 4 of the European Board of Accreditation in Hematology. So, dear audience, please welcome with me the speaker of today's session, Professor Paul Brinkkötter, who will lead the session on Caplacizumab and treatment of immune-mediated thrombotic thrombocytopenic purpura without plasma exchange. Professor Brinkkötter is Professor of Medicine and Nephrology at the University of Cologne, Germany, with a deep interest in glomerular diseases and thrombotic microangiopathies, including immune-mediated thrombotic thrombocytopenic purpura and atypical hemolytic uremic syndrome. He participated in the Center for Rare Disease at University of Cologne, and he's involved in primary care of patients with TMAs, both within the hospital and in an ambulatory setting. So, Professor Brinkkötter, the floor is yours. Thank you.
Dear Mariangela, thank you very much for your kind introduction. Good afternoon, dear colleagues. As already mentioned, my name is Paul Brinkkötter, and I'm Professor of Medicine at the University Hospital in Cologne. For my background, I'm a nephrologist, so I feel honored to be here today and to have the opportunity to speak to you. To begin, I would like to thank the organizers for this webinar series. I think they put together a fabulous program. And I was asked to talk about Caplacizumab and treatment of iTTP without plasma exchange. My presentation will last for about 30 minutes, and we will have plenty of time for your questions. So I encourage you to use the chat to send your questions during the presentations and to engage in a discussion. To begin, I would like to disclose my potential conflicts of interest. Today's seminar builds upon the previous presentations on the pathophysiology of immune-mediated and therefore acquired TTP. You have learned a lot about the diagnostic workup for TTP and TMA syndromes to make the correct diagnosis. And a few weeks ago, Paul Coppo summarized our current treatment strategies. Before I talk about plasma separation and its role in the treatment of TTP, I would like to make a very clear statement. Our current treatment paradigm to treat acute episodes of iTTP is and will be for the next months and years to come based on the combination of plasma exchange to remove the inhibitory antibodies and to replace ADAMTIR13, the use of the anti-von Willebrand factor drug Caplacizumab, which limits microthrombi formation, and of course immunosuppression, and in most cases the combination of steroids and rituximab. Today, I will summarize the current knowledge on treatment of iTTP without plasma exchange. However, and again, this is very important to remember, we need more clinical data, we need more clinical trials to validate these approaches before they can be considered standard of care. So, why shall we change a winning formula? This is my agenda. I will first briefly summarize the role of plasma separation in the treatment of TTP before I talk about plasma exchange-free approaches with and without the use of Caplacizumab. And in the end, I will close and discuss with you a clinical algorithm for the acute management of iTTP. Okay, let's get started. Our understanding of the disease and the treatment of TTP now dates back almost 100 years. Over the past 4 decades, our understanding of the underlying disease mechanisms has led us to refine our treatment modalities. The treatment of iTTP has become a success story. Initially, mortality was very high, and now it's curable or treatable. The treatment is a real success, and iTTP has lost much of its terror as compared when Eli Moshkowitz described his first case in 1924. With respect to plasma separation, in 1991, Gail Rock from Canada published her landmark study in the New England Journal of Medicine comparing plasma exchange to plasma infusions in patients with TTP. In detail, the authors included 102 patients with thrombotic thrombocytopenic purpura. The patients were randomly assigned to receive either plasma exchange or plasma infusions. And I depicted the most relevant finding on this slide. Plasma exchange was clearly more effective and superior than plasma infusions in the treatment of acute thrombotic thrombocytopenic purpura. And as an immediate consequence, PEX was now considered the standard treatment for acute episodes of iTTP. In the same issue of the New England Journal, there was another publication looking at glucocorticoids and the use of steroids to treat acute episodes of TTP, and both basically made it to be the standard for that time until today, if you wish. In the following slides, I will now briefly review the basic concept of plasma exchange. I really recommend you to read the review in CJSON on this topic. I'm a nephrologist and I'm used to work with dialysis machines to clear the blood from urinic toxins. However, larger molecules greater than 65 kilodaltons will not be removed by our conventional dialysis filters. And this is actually what we aim for when we treat patients with aggressive autoimmune diseases, such as immune-mediated TTP. The exchange of patient plasma allows us to remove autoantibodies. And when talking about TTP, we primarily talk about IgG antibodies. And here it's more important to keep in mind that only 40 to 70% of the antibodies are actually found within the bloodstream. This schematic drawing depicts a hollow fiber membrane, which is widely used for plasma exchange. The whole blood flows along the interior of the fiber. Soluble plasma components, including immunoglobulins, albumin, immune complexes, but also clotting factors, fibrinogen, and many other compounds, can easily pass through the pores and will be filtered. However, the core components, the cellular components, the red blood cells, the platelets, the white blood cells, will not. To do so, we need first a large venous access. In most cases, a central venous catheter is placed primarily in the jugular vein or in the femoral veins. We need anticoagulation. Often citrate is used to avoid clotting while the blood is running through the extracorporeal circulation. We need a plasma filter and of course a replacement solution. So when we exchange the patient's plasma, we have to replace it, and we can use plasma or albumin. And when we talk about TTP, in most cases, we use fresh frozen plasma. And the procedure itself is very efficient in removing, for example, immunoglobulins. And this is shown down here. The authors compared two different filters, and the sieving coefficient for immunoglobulins is 1, meaning that almost all immunoglobulins are cleared. Just for you to, as a comparison, on the right are the numbers for a dialysis filter. And as you can see here, immunoglobulins are not cleared when we dialyze our patients, as you would expect. So the procedure itself is very efficient. However, and I already mentioned this fact, only 40 to 70% of the body's immunoglobulins are circulating in the bloodstream. The remaining 30 to 60% can be found in the lymphatic tissues, including the spleen. This is of great importance for our treatment strategies and actually does explain the rebound effects that we observe after each PEC session. So we are able to remove IgGs, but as soon as we stop the procedure, the concentration in the blood will increase. So we have to repeat our procedure several times. And if you combine, if you draw a line through the procedure and measurements, you will see that we reach a certain saturation, and it will take a very, very long time, if at all possible, to remove all of the initial immunoglobulins from a patient. It's almost impossible. And actually, this is true for both membrane separation or centrifugation-based plasma exchange. So some of you may use membrane separation, as most centers do in Europe, but there is also a second method which is based on centrifugation. But it basically doesn't matter which kind of procedure you perform. The efficacy to exchange the plasma and larger molecules is comparable between the two methods. Now I come to my second objective and I will continue with the treatment strategies of immune-mediated TTP without plasma exchange prior to the advent of Caplacizumab. The concept to treat patients with acute episodes of TTP without plasma separation is not new. And some of you may know what is called the Jehovah's Witness experience. The fact that some patients refuse the transfusion of certain blood donor-derived products because of religious beliefs. A few years ago, James George and colleagues published a very interesting case report on this and also performed a literature search of similar cases. In the meantime, there have been additional reports on this topic with similar outcomes and strategies. Basically, they report on a 46-year-old white woman who presented to the emergency department with primarily neurological symptoms, including transient aphasia. She was diagnosed with iTTP and treated with high-dose glucocorticoids, rituximab, and also apheresis. After 1 week, she experienced a disease exacerbation, and again, even higher doses of methylprednisolone were administered. Eventually, she gradually felt better and could be discharged after 28 days. And the patient returned to work after 60 days. So all in all, a very successful treatment. Similar cases had been published in the years before, describing patients between 19 and 56 years of age, all women. The treatment regimes were heterogeneous. Most of the patients received glucocorticoids, but the immunosuppression varied. Some used vincristine, others rituximab, some used apheresis, others don't. But all in all patients recovered, and a favorable outcome was reported. In their paper, the authors concluded with specific recommendations how to treat patients with iTTP who refuse plasma exchange. And these recommendations include the administration of rituximab twice weekly for 2 weeks, so an intensified schedule, if you wish. High-dose methylprednisolone, 1 gram per day for 3 days, followed by more conventional doses. And they also recommend the application of erythropoietin and folic acid to support the erythropoiesis. In case the thrombocytopenia persists, factor VIII von Willebrand factor replacement therapy, CoA8, may be considered to provide ADAMTS13, and of course, additional immunosuppressive agents or apheresis with albumin are additional options in case the patient does not respond to the initial therapy. There are 2 more interesting aspects in this paper. The authors also speculate on the role of new treatments for TTP, including Caplacizumab, a nanobody that blocks von Willebrand factor interaction with platelets, and also recombinant ADAMTS13 to provide ADAMTS13 activity to the patient. And they hypothesize that these new treatment options may provide a major benefit for these patients. And in another paragraph, they make this very remarkable statement that the possibility that PEGs may not be essential in the treatment of TTP, that basically we learn a lesson from these case reports. But why should we change our winning formula? The published data from Rock and colleagues, together with the real-world experience of many centers around the world, have proven plasma exchange to be very efficient when treating patients with iTTP. So why shall we change it? And here published data from the Oklahoma TTP registry helps us to shed light on potential side effects, adverse reactions to plasma separation. In several papers, the authors report on cases that actually died because of complications of plasma separations, 3 out of 78, so 4%. 2 because of sepsis, 1 because of a severe hemorrhage caused by central venous catheter insertion, which is not unlikely considering the low platelet count. 12 additional patients, another 18%, experienced sepsis with documented bacteremia related to their venous catheter. 3 suffered from thrombosis requiring systemic anticoagulation, and of course, there are reports on anaphylactic reactions. And in this cohort, there was 1 patient that actually experienced or suffered from a cardiac arrest, but she had a complete recovery. Moreover, there are additional complications. So electrolyte disturbances, hypocalcemia is one to mention. Citrus is often used as regional anticoagulation. Citrate exerts its anticoagulation effect by chelating ionized calcium, an essential component in the clotting cascade. As a consequence, you have to replace calcium. Otherwise, you will end up with severe hypocalcemia. Moreover, citrus is metabolized in the liver to bicarbonate. The alkali load itself leads to the reduction of the intratubular reabsorption of citrate, and hence more citrate is later excreted via the urine. However, and I think this is important to keep in mind, bicarbonate may accumulate, in particular in patients with impaired liver function, resulting in metabolic alkalosis. And last, any plasma separation procedure requires very specialized and trained personnel and instruments that may not be available in many hospitals or at all times. And this is not only a problem in rural areas or less developed countries, as we have just learned in the ongoing COVID-19 pandemic, when simply the resources are limited. So I was personally involved in one case in a rural area in Germany where it was impossible to administer, to deliver the PEGs in time. So the patient was treated without plasma separation successfully. And this brings me now to my third objective, the impact of Caplacizumab. I'm confident that you are all aware of Mary Scully's landmark paper published in the New England Journal of Medicine in early 2019, the phase 3 Hercules trial on Caplacizumab treatment. I will not go into detail because I'm sure Paul Coppo has reviewed and summarized these findings. Caplacizumab, a nanobody that blocks the binding of thrombocytes to large von Willebrand factor multimers, resulted in a faster thrombocyte response, as shown here in blue. The paper was published in January of 2019, and a few months later, so now we're talking about July, the first case report on the use of Caplacizumab without plasma separation was published. The authors report on an initial episode of TTP in a 63-year-old woman who presented with spontaneous purpura. Again, she was a Jehovah's Witness and refused plasma exchange because of religious prohibition. And if you take a closer look at this slide, you see in blue the low platelet count for several days. And the patient, she received glucocorticoids and rituximab. And in orange is the hemoglobin. And she pretty much did not respond within the first 2 weeks. And on day 11, the treating physicians administered Caplacizumab. At that time, it was not officially approved by the FDA, so or widely available at least, and the authors got access to an early access program of the company. And upon application of Caplacizumab, the platelets started to rise, and the patient recovered and could be discharged after after 20 days. And a few weeks later, the adaptor 13 activity also recovered and it normalized. This was actually the first case where Caplacizumab was used, or the first published case where Caplacizumab was used for a PEGs-free treatment approach. Another few months later, now we're talking about April of 2020, another case was published. At this time, a patient with a known history of immune-mediated thrombotic thrombocytopenic purpura. The patient was a 56-year-old woman, and she came in for a scheduled 3-month follow-up evaluation and reported generalized fatigue, abdominal pain, and nausea for the previous 4 days. She had a long history of TTP, if I remember correctly, 10 years or so. And when she presented, her platelet count was low, 86,000. 3 months previously, it had been more than 200,000. Her hemoglobin was 12.7, and the lactate dehydrogenase, the LDH level, was 270, so slightly above the limit of normal. The blood smear had many schistocytes, so that the treating physician just diagnosed a TTP relapse. However, the patient asked and approached the treating physician if hospitalization, the placement of a central venous catheter, plasma exchange, and even glucocorticoids could be avoided. She was well enough to remain at home with support of her family, and in the past she had experienced multiple difficulties and side effects with all of these conventional components of TTP treatment. And after a thorough discussion about potential limitations and risks of not being hospitalized on the one hand, and of not being treated with plasma exchange and corticosteroids on the other, a shared decision was made that she was only treated with Caplacizumab and rituximab. And this is basically the outcome. So here you have the low ADAMTS13 activity, platelets slightly above 100, slightly below 100,000, And she received Caplacizumab, and within 3 days, the platelet count normalized, and we see a little bit of an overshooting response, and then it reaches the normal levels for this patient. And she received 4 doses of rituximab, and after 60 days, the ADAMTS13 activity was back up to normal levels again. In the meantime, 6 additional patients have been treated in Germany and Austria with Caplacizumab and without PEGs. And together we published this case series. And I would like to introduce one special case which was very educative for us. We treated a 46-year-old white female patient with a known history of iTTP. Her initial episode dates back to the year 2002, and she was in remission ever since. She now presented with fatigue, hematomas, petechia, and gingival bleeding to our emergency department. And she had the typical TMA picture, including renal failure. Creatinine was 0.8, but her baseline was 0.5, and she had significant levels of albuminuria and Coombs negative microangiopathic hemolysis and thrombocytopenia. The thrombocyte, the platelet count was 10,000. The diagnosis, iTTP, was later confirmed when the laboratory reported an ADAMTS13 activity below the limit of detection and high inhibitory antibodies. We administered the first dose of Caplacizumab together with high-dose glucocorticoids within the first hour when the patient was still in our emergency department. And I would like to draw your attention to the blue line, which reflects the platelet count. We closely monitored the platelet response and observed a very rapid and robust response. Within 3 hours, the platelet count almost doubled to 20,000 thrombocytes. After 6 hours, the platelets reached 30,000, and after 48 hours, the platelet exceeded 100,000. Given this rapid response and also a clinical improvement, the patient was very hesitant to get a central line placed and to start plasma separation. And very similar to our colleagues and friends in the US, we discussed the potential limitations and the risk of not being treated with plasma exchange, but then agreed on closely monitoring the platelet response, the platelet count, and clinical symptoms with plasma exchange as backup strategy if platelets start to decline or clinical symptoms aggravate. Eventually, she did fine, and we could discharge her after 5 days. As stated earlier, we summarized in our case series the clinical response of 6 patients. All patients recovered rapidly, showing a normalization of their platelet count within 3 to 4 days. So a very rapid response. These 6 patients comprised patients with known history of TTP, but also I think it was 2 cases where this was the initial episode. Some had severe lab abnormalities as our patients with very low platelets at around 10,000. Others had rather mild symptoms or rather mild laboratory findings, very similar to the case from the US. All patients responded very well and could be discharged within a few days. Which now brings me to my last point, a proposed algorithm for acute management of immune-mediated thrombocytopenic purpura. First, I think it's essential to make the correct diagnosis quickly. And this includes, from my point of view, the measurement of ADAMTS13 activity within 1 or 2 days. I'm well aware of the current situation and the limited availability of ADAMTS13 testing, but we have to improve this. I showed you the published data and potential adverse events of plasma exchange. Plasma exchange is not only beneficial, it may also poses a certain risk. And the only TMA condition where we have convincing evidence for the use of plasma separation is TTP. So we really want to be sure to make the correct diagnosis and to treat the right patient with the appropriate procedure. If we make the diagnosis TTP, we should start our patients on high-dose steroids together with Caplacizumab and rituximab within the first 72 hours. The standard of care does also include plasma exchange. However, in experienced centers and with a close monitoring of both platelet counts and clinical symptoms, one may withhold on an immediate plasma separation, but have it as a backup if the patient does not respond, platelets do not increase, or clinical symptoms aggravate. Whenever such approach is pursued, it is of course obligatory to inform the patient thoroughly about potential risks and benefits. And such an approach might also be useful if patients have to be transferred from smaller sites to larger hospitals. Apply the first dose of Caplacizumab in the smaller hospital and then transfer the patients, and do not withhold the therapy. And then, of course, you have to monitor the platelet count and the ADAMTS13 activity to decide whether to stop plasma separation or to initiate if you haven't started to begin with, and to monitor the treatment duration. With this, I would like to end my presentation, and I'm looking forward to your question. Thank you very much for your attention. I hope I stayed in time, and now please send me your question in the chat. I'm looking forward to discuss all your questions with you. Thank you.
Thank you very much, Professor Brinkkötter, for this great presentation, very exhaustive, and you are perfectly on time. I can reassure you. So we have plenty of time for questions. So I really encourage the chat to write the questions, because it's an unique occasion for directly ask to the expert the question. So we have the first one.
Right. So I will read the question so everybody
sure.
understands what I'm talking about. So the first question comes from Anna Paula. So are you aware of trials about iTTP without PEGs? I've heard that the company is thinking about, Sanofi is thinking about such a trial, but it's very early, and we'll have to see and wait. I do hope that at some point we will have a clinical trial, basically to generate the data that is needed to basically answer this important question. But again, I think it's not that easy to perform such a trial, because from my point of view, it's really essential to have a fast ADAMTS13 activity measurement at place, and then you really have to make the right diagnosis before you start treating your patient. And right now, in most institutions, we start them on plasma separation, and then a few days later we get our results back and then decide, okay, is it a TTP or is it HUS or a STEC HUS or any other TMA, and then basically guide our treatment accordingly. There's another question on potential immune modulatory effects of plasma infusion or plasma exchange, and whether these may help to overcome the autoimmune activity as seen in iTTP. And what is my opinion on this? And could avoiding PEGs lead to an increased need for immunosuppression? Well, honestly, I cannot answer this this question. It's widely discussed. I think there is circumstantial data from several disease conditions where plasma exchange does have an immune modulatory effect. So it's not only the removal of the antibody, but it's also reprogramming our immune system. To what extent this plays a role when in TTP is not well understood. So I have to speculate on this. And I think at the end of the day, the more specific we can be with our treatment, the better we will be, and the greater is our success. And plasma exchange is not a specific therapy. I hope this answers the question. And there's another question. According to your opinion, how can be the overall cost analysis of Caplacizumab without PEGs versus the traditional PEGs regime? Well, another very good question. For my experience, the plasma separation is not the cost driver. Right now, it's the length of the hospital stay, the days on the ICU, and of course, Caplacizumab, which is a very expensive drug. However, if you envision treating patients in an ambulatory setting, as did our colleagues in the US, where they recognized a relapse very early, so the patient did not even have to be admitted to the hospital, this of course would be a game changer. So now there are a few more. Is there any information about ADAMTS13 activity levels from the plasma of donors used in TTP? It's not routinely measured, and since it's derived from healthy donors, I would assume normal levels, but it's not routinely tested. And did you observe a more rapid normalization of platelets in patients treated with plasma exchange than in patients treated with a PEGs-free regime? Well, we did not. It was about the same. So in the Hercules trial and in the real world data, it took around about 3 to 4 days for the platelets to reach levels above 150,000. And we observed the same response in the few patients that we oversee that were treated without plasma separation. The next question, in our last 2 cases, 2 adolescent females, I had the clear feeling that the PEGs was not useful, only the addition of the rituximab led to the relucent. I totally agree. So again, I think rituximab is key. It's depletes CD20 positive B cells. It helps us to control the immune activity, to reduce the antibody production. And with Caplacizumab, we now have a new drug in our armamentary that helps us basically to bridge the time from the initial therapy until the immunosuppression kicks in and is so suppressive that the B cells do not produce the antibodies anymore. And actually, I don't know how you do it at your hospital. So in the past, we used to continue plasma exchange for at least 2 days in addition to basically reaching 150,000. So basically, once the patient reached the level of 150,000 platelets, we continued to plasma exchange the patient for additional 2 days. And as far as I know, this was, a common procedure. Nowadays, we stop as early as we can and as soon as we can. If not responding or relapsing on PEGs, should be PEGs discontinued when starting. When starting PEGs? On Caplacizumab. So patients not responding to Caplacizumab or relapsing. So to be honest, I haven't seen a single patient that did not respond to Caplacizumab, and we now oversee more than 100 patients that were treated in Germany. So in Germany, around about 200, 250 patients have been treated with Caplacizumab over the last 2.5 years. And as far as I know, there was not a single case that did not respond to the treatment. I do know of some cases where the diagnosis was incorrect, where they were started on Caplacizumab and then it turned out that it was not a TTP, but a secondary TMA. And so to answer your question, should be PECs when to restart PECs. So I think if you have a case where you're and the patient is on Caplacizumab and is relapsing, again, I think it's important to keep in mind that we do observe a very high, very dynamic thrombocyte response. So it's not just one measurement that should be considered, but rather we should look at the whole picture, not only at thrombocyte, but also at other markers for hemolysis. We should look at the clinical symptoms. And if there's clear evidence for relapse, then of course I would reinitiate or initiate plasma separation and then administer Caplacizumab after the PEC session. I hope this answers the question. If not, please write to me in the chat. And how long do you keep steroid once platelets recovered? Well, we follow very much the Hercules study protocol. So usually we aim to taper the steroids rapidly, and the patient should be off steroids after 4 weeks. And this is usually the time the rituximab needs basically to exert its effect. And once the antibody drops, the activity will come back up. So in the German cohort, it was round about 21 days after the last plasma separation for the median time for the ADAMTS13 activity to recover.
So I want to thank again Professor Brinkkötter.